Arteritis. Temporal Karl T. Klebuck, M.D., Foft Munima Nasir, M.D. Chloe S. Kirshen, M.D. Basics description technically termed giant cell arteritis, GCA, a chronic, generalized, cellular, and humoral immune-mediated vasculitis of large and medium-sized vessels, predominantly affecting the cranial arteries originating from the aortic arch, although vascular involvement may be widespread. Inflammation of the aorta is observed in 50% of cases. Frequent features include fatigue, headaches, jaw claudication, loss of vision, scalp tenderness, polymyalgia rheumatica, PMR, and aortic arch syndrome, decreased or absent peripheral pulses, discrepancies of blood pressure, arterial brutes. Considered medical emergency due to risk of permanent vision loss if not treated. Epidemiology. Most common form of systemic vasculitis affecting persons greater than or equal to 50 years old typically occurs ages 70 to 80 years. 80% of cases, women are affected about 2 times as often as men. Most common vasculitis in individuals of Northern European descent, Scandinavian countries, rare in Asians and African Americans. Lower body mass index, BMI, associated with increased risk. Incidence prevalence in individuals greater than 50 years, 1 in 500 peaks in patients greater than 70 years old. Prevalence 2 per 1,000 persons. Etiology and pathophysiology. The exact etiology of GCA remains unknown, although current theory suggests that advanced age, ethnicity, and specific genetic predisposition lead to a maladaptive response to endothelial injury, intimal hyperplasia, and ultimately vascular stenosis. Temporal arteritis, TAA, is a chronic, systemic vasculitis primarily affecting the elastic lamina of medium and large-sized arteries. Histopathology of affected arteries is marked by transmural inflammation of the intima, media, and adventitia, as well as patchy infiltration by lymphocytes, macrophages, and multinucleated giant cells. Mural hyperplasia can result in arterial luminal narrowing, resulting in subsequent distal ischemia. Current theory regarding the etiology of TA is that a maladaptive response to endothelial injury leads to an inappropriate activation of T-cell-mediated immunity via immature antigen-presenting cells. The subsequent release of cytokines within the arterial vessel wall can attract macrophages and multinucleated giant cells, which form granulomatous infiltrates and give diseased vessels their characteristic histology. This also leads to an oligoclonal expansion of T cells directed against antigens in or near the elastic lamina. Ultimately, this cascade results in vessel wall damage, intimal hyperplasia, and eventual stenotic occlusion. In recent years, GCA and PMR have increasingly been considered to be closely related conditions. Varicella-Zoster virus has been proposed as possible immune trigger for GCA, however, this has not been substantiated, and adjunctive treatment with antivirals remains controversial. Genetics. The genes HLA-DRB104 has been identified as a risk factor for TA, and polymorphisms of ICAM1 and PTPN22 have also been implicated. Risk factors. Increasing age greater than 70 years is the greatest risk factor. Genetic predisposition. Environmental factors influence susceptibility. History of smoking. Early menopause, 43 years, and lower BMI at menopause in women 50 to 69 years old. Commonly associated conditions. Population studies have shown 40–60% of patients diagnosed with GCA also have PMR symptoms, and 16–21% of patients with PMR have GCA. Diagnosis. History. Most common presenting symptom is headache, 2/3 of patients. Constitutional symptoms, fever, fatigue, weight loss, any visual disturbances, amaurosis fugax, diplopia, vision loss, 20% of patients. Unilateral is most common, often proceeds to bilateral if untreated. Jaw claudication, presence of symptoms significantly increases likelihood of a positive biopsy. Scalp tenderness or sensitivity. Claudication of upper extremities or tongue. Symptoms of PMR, shoulder and hip girdle pain and stiffness, distal extremity swelling/edema. Upper respiratory symptoms. Physical exam. Temporal artery abnormalities, beating, prominence, tenderness, typically appear ill. Decreased peripheral pulses in the presence of large vessel diseases. Fundoscopic exam shows pale and edema of the optic disc, scattered cotton wool patches, and small hemorrhages. Unlike other forms of vasculitis, GCA rarely involves the skin, kidneys, and lungs. Brute supraclavicular, axillary, supraorbital differential diagnosis. Migraines. Herpes zoster. Other vasculitis, Takayasu arteritis, Wegener, polyarteritis nodosa. Other rheumatologic condition, rheumatoid arthritis, PMR, mixed connective tissue disease. Diagnostic tests and interpretation. American College of Rheumatology 1990 classification criteria are as follows. Age greater than 50 years. New localized headache. Temporal artery abnormality, tenderness to palpation, decreased or absent pulses, erythrocyte sedimentation rate, ESR, greater than 50 mm/HR. Abnormal temporal artery biopsy showing vasculitis with predominance of mononuclear cell infiltration or granulomatous inflammation. 3 or more of the ACR criteria demonstrate a sensitivity of 94.5% and a specificity of 91.2%. Initial tests, lab, imaging, ESR greater than 50 mm/HR, 86% sensitivity, although nonspecific, 27%, infrequently, may be normal. C-reactive protein, CRP, greater than 2.45 mg/dl is a more sensitive marker of inflammation, 97% sensitivity, and is associated with increased odds of a positive biopsy result. A normal ESR/N/or CRP renders the diagnosis of GCA unlikely. Acute phase reactants, fibrinogen, interleukin-6, are frequently elevated but very nonspecific and reserved for diagnostically difficult cases. Mild anemia, very nonspecific but may be associated with a lower rate of ischemic complications. Color Doppler ultrasound, US, of the temporal artery may identify vascular occlusion, stenosis, or edema. Halo sign, it is low cost and non-invasive but also very operator dependent and does not significantly improve on the clinical exam. It may aid in the diagnosis of larger vessel involvement. Atherosclerotic disease with carotid intima media thickness greater than 0.9 mm may mimic halo sign. Magnetic resonance imaging, MRI, and magnetic resonance angiography, MRA, may be beneficial in diagnosis, 78% sensitive, 90% specific, if performed within 5 days of steroids. Positron emission tomography, PET, like MRI/MRA and color Doppler, may be useful in diagnostically difficult cases to quantify the inflammatory burden and early in the course of disease, as the metabolic changes occur prior to structural vascular damage, but it also lacks studies to support its use. Follow-up tests and special considerations. Development of aortic aneurysms, late and potentially serious complication of GCA, can lead to aortic dissection. Due to the risk of irreversible vision loss, treatment with high-dose steroids should be started on strong clinical suspicion of TA, prior to the temporal biopsy being done. Diagnostic procedures/other gold standard diagnostic study, histopathologic examination of the temporal artery biopsy specimen. Do not delay starting medication if suspicion, as pathology remains up to 14 days after starting steroids. Overall sensitivity is 87%. The temporal artery is chosen because of its accessibility in the systemic disease. Alternatively, facial artery or other cranial arteries may be used. Length of biopsy specimen should be at least 2 cm to avoid false negative results because skip lesions may occur. Diagnostic yield of biopsy may be increased if procedure is coupled with imaging, high-resolution MRI or color Doppler US. Bilateral temporal artery biopsy should not be performed, unless the initial histopathology is negative and the suspicion for GCA remains high. May be negative in up to 42% of patients with GCA, especially in large vessel disease, and a negative biopsy alone should not dictate treatment. Biopsy results are not affected by prior glucocorticoids, so treatment should not be delayed. Test interpretation. Inflammation of the arterial wall, with fragmentation and disruption of the internal elastic lamina. Multinucleated giant cells are found in 50% of cases and are not specific for the disease. TA occurs in 3 histologic patterns: classic, atypical, and healed. Treatment medication. First-line glucocorticoids. The typical dose of prednisone is between 40 and 60 mg/day, or 1 mg/kg/day, and the dose may be titrated up to relieve symptoms. Steroids should not be in the form of alternate-day therapy because this is more likely to lead to a relapse of vasculitis. 1a. 4 steroids indicated if vision loss has been noted, otherwise post-steroids are equally as effective. 1c. Given risk of irreversible vision loss, immediate steroid therapy should be initiated prior to confirmation by biopsy. The initial dose of steroids is continued for 2 to 4 weeks and slowly tapered over 9 to 12 months. Tapering may require greater than or equal to 2 years. 1a. Assess for relapse during taper by monitoring symptoms, ESR, CRP. Tocilizumab, an IL-6 receptor antagonist, 162 mg² weekly or biweekly. Indiana addition to prednisone may be superior to prednisone alone, although it does carry a black box warning regarding increased risk of opportunistic infections. 2b. It has been suggested that low-dose aspirin might be effective for patients with GCA. 3b. Second-line methotrexate as an adjunct to glucocorticoid therapy may have a modest effect in decreasing the relapse rate of TA. 4a. Cyclophosphamide have shown some benefit in patients who have not adequately responded to glucocorticoids. 5a. Therapies directed at tumor necrosis factor as adjunct to steroids have not shown significant benefit. 1b. Ongoing care. Follow-up recommendations. Sun avoidance and protection of the head and the face from photoimage may eventually prove to be important preventive measures for TA. Patient monitoring. TA is typically self-limited and lasts several months or years. Overall, TA does not seem to decrease longevity. Nevertheless, it may lead to serious complications such as visual loss, which occurs in about 15–20% of patients. Another complication of GCA is the development of aortic aneurysms, usually affecting the ascending aorta. Yearly, chest X-rays may be useful to identify this problem. 6c. About 50% of the patients with GCA will eventually develop PMR, stiffness of shoulder and hip girdle. Low-dose aspirin should be given as indicated by atherosclerosis guidelines. Diet. Calcium and vitamin D supplementation should be administered for osteoporosis prevention associated with prolonged corticosteroid therapy. Patient education. Consequences of discontinuing steroids abruptly: adrenal insufficiency, disease relapse, risks of long-term steroid use, infection, hyperglycemia, weight gain, impaired wound healing, osteoporosis, hypertension, possibility of relapse and importance of reporting new headaches and vision changes to provider immediately. Prognosis. Variable duration of disease, from 1 year to chronic course. Life expectancy is not affected by the disease unless severe aortitis is present. Once vision loss has occurred, it is unlikely to be recovered, but treatment resolves the other symptoms and prevents future vision loss and stroke. In most patients, glucocorticoid therapy can eventually be discontinued without complications. In patients with chronic disease, however, prednisone may need to be continued for years. Disease relapse is possible. Complications. Vision loss with delayed diagnosis. Glucocorticoid-related toxicity.